Well, good afternoon, everyone. I appreciate everybody coming out today. This is the first of several stops that we're going to have to discuss Osawatomie's future with Correct Care Recovery Solutions is where we're starting today. I am Tim Keck. I'm the Secretary for KDADS. I think many of you in the room know who I am. I know many of you from the visits I've made down here, and I know there's a lot of questions and concerns among staff about why we're here today. I want to start where I start with most of my meetings and remind you all of my contact information. I give this out, given it out all over Kansas. Email address is on the board over here. That's my personal cell phone number, and I've heard from many of you at different times. And then my Twitter account, my professional Twitter account is at Secretary. So, but with that, we'll go ahead and get started. Again, I'm Tim Keck, the Secretary at KDADS. This is Nikki Gillen. She's a special assistant to me, does a lot with the hospitals, among other things. You know, Dr. Worley, Ben Rao, Dr. Castillo back there, Cody Gwaltney is legislative staff. Kalea Porter is an attorney with us and has been working on the RFP. I'm going to give Correct Care Recovery Solutions a chance to introduce their folks. They're here today. So Jeremy, do you mind standing up and introducing folks? Patrick, sorry about that. Sorry about that.
Patrick Comiskey, I'm President of Correct Care Recovery Solutions, CCS. And with me today we have Lee. You want to stand up and introduce yourself?
Good afternoon. I'm Lee Packer. I'm the hospital administrator for one of our Florida facilities.
Jeremy Barr.
Jeremy Barr, I'm the Vice President of Correct Care Recovery Solutions, and I appreciate all of you showing up today.
And Karen from...
Hi, I'm Karen Galen. I'm the Chief of Behavioral Health for CCS.
One of the important partners in this project for us was Canon Design. Canon Design is the largest designer of behavioral health facilities in this country. They have facilities in 35 different states. And so from Canon Design, we also have...
Stephanie Vito, an architect at Canon Design. Nice to see you all today.
Thank you for allowing us to be here.
Yeah, thank you. Appreciate you coming today. I wanted to give you a little more information. We have additional public forums to talk about Osawatomie's future. Today is the first one that we're doing, and we have another one on the 24th of August in Wichita at 615 North Main. We have another one on the 29th of August in Independence at Ford County Mental Health Center. Another one on August 30th at the Capitol in Topeka in one of the conference rooms in the near the Visitors Center. And then the last one will be in Kansas City on September 8th. That's a Friday. Various times. We'll have this posted on the website. I have a PowerPoint that I'm going to go through today. It's pretty extensive from all the work that's been done over the last several years. I'm not going to go through every page. We do have slides available that we provided to people as they've come in. We didn't make enough for everybody, but we will post this on our website, KDAD's website, so it's available to you later today or tomorrow. I think we have some other copies being made. We want to get more information to people, not less. It's an important issue going forward, and we want to have an in-depth discussion with you all about where we are. Recently, I was given this book, and it's titled Reform at Osawatomie State Hospital. It was written in about 1972, 1971 by Dr. Lowell Arthur Gish. Some of you may know Dr. Gish. But it's a pretty thick book about Osawatomie and its history. And I'll start there. On November 5th, 1866, a sullen, somewhat belligerent young man was escorted with some force into a renovated farmhouse on a hill above Osawatomie. And thus started the hospital here at Osawatomie State Hospital. It's been in existence since that time. Last November, we celebrated the 150th anniversary of Osawatomie State Hospital. I have been I think a big supporter of the hospital here, remaining here in Osawatomie, and I want to make that clear from the get-go that this is where the hospital should be. There's been a huge commitment from this community for 150 years and back and forth. The hospital's ingrained here, and in my mind, this is where a state hospital should remain going forward. We've worked endlessly and tirelessly to try to make that happen going forward. It won't happen overnight. But we want to have a state hospital here at Osawatomie State Hospital and a renewed hospital at Osawatomie State Hospital. So we'll go ahead and get started with the PowerPoint, talk to you about where we've been since October of 2014. In October 2014 began a period of about 3 years now where we've had surveys being done at Osawatomie State Hospital. With a complaint survey in October of 2014, that began the survey process as we went forward. And we've continued under those various surveys until December of 2015 when we were decertified. And you all know that we've remained decertified since that time. We've made some adjustments to parts of ADARE to try to get us recertified going forward on 60 beds because of the cost of the renovation. And this is an indication of the cost of the renovation on ADARE and the estimates for the rest of the hospital if we would try to renovate the rest of the hospital as opposed to building something new. So that leads us to where we are today. We stand decertified as a result of these complaint surveys and other surveys that happened over about a 1.5 year period of time that ended in a decertification in December of 2015. At that time, we were decertified essentially for 2 reasons. One, the lack of staffing and staff training, and the physical environment. And if you work here, you know what I'm talking about. The most recent building that was built, where the patients are housed at Osawatomie, was built in 1961. So it's 55 years old now at this point. And so the reason we were decertified for the physical environment is because of the ligature points that come with an older hospital, places where people could hang themselves. The drop ceiling, similar to what we had here. The doorknobs didn't meet conditions of CMS. Bathroom fixtures, drinking fountains, really everything was out of compliance with CMS regulations for ligature points. And that was the first slide we showed you, is what it would cost to replace all of that. In September, we'll have added another 12 beds on the licensed side, and hopefully that will help alleviate much of that waiting list that we see every day. I get an email every day that lists the waiting list. It's part of a call that we have every morning about the hospital, and it's, as I said, it's fluctuated from 35 to I think today is the lowest I've seen it at 4 people. So as a result of the bed availability list, there's a wait of about 48 hours for people who are not OTO. The OTO wait is about 233 hours. Since September 2016, the formal opening of AAC, the average time on the bed availability list is about 63 hours for other than those on the OTO. So that's where we are. That's where we are in that regard. I'll do a quick overview of the hospital in general. Many of you, if you work here, you know more about this than I do. As I said, the hospital began operating in November of 1866. As I read through that book, the first patient was a young man who was, of course, recalcitrant. He apparently was also the first elopement from Osawatomie State Hospital, and that he eloped just a day or so later. So CMS would not have liked that, I'm sure, but it didn't exist at that time. So we'll do a quick overview. The next slide is an aerial view of Osawatomie State Hospital as it stands today. And then the administration building is the next slide, and that was built in 1986. I think it's the most recently built building on the campus. The middle building was constructed in 1952. Some inside of the dining hall. A DARE complex was constructed, I think, between 1959 and 1961. ADARE Acute Care is the next slide. It's ADARE Acute Care at Osawatomie State Hospital that functions as a 60-bed unique hospital that we've talked about that we're trying to get recertified on. The day hall there is the next slide. Kind of give you an idea, if you've not been on the floors, what it looks like. Patient and staff meet to develop a treatment plan. Examination rooms for physical issues. Nourishment rooms. Keeping up okay with me, Nikki? Okay. Okay. On that unit, or at that hospital, each patient room is designed with safety furniture. So if you are not an employee here, you know that those beds and the chairs and everything else is weighted to prevent them from being used in some fashion during an altercation. So that bed probably weighs 200 pounds, 300 pounds or so. The chairs weigh about 70 pounds, are weighted with sand. The cubby there is the closet for the patient, and there, if you look at it closely, you can see there are no ligature points. Those are all things that we had to do to get to seek recertification. We'll continue through the group rooms. It's a hub for the staff. Even the phones have ligature concerns. The length of the cord, if it's too long, it creates a ligature concern for the patients. Laundry equipment is available to the patients. So that's all at the Adair complex. The Biddle Annex is next. And we'll flip through that pretty quick, Nikki. Rehabilitation center with a swimming pool, activity center, power plant. Again, all of these were built, again, the most recent building that was built was in 1986, and it's a building that we're in today, where we're standing today. Maintenance complex. Laundry was built in 1961, fire station in 1957, and on and on. 1911, 1912, Nurse's Cottage. Rush was 1931. That's one of the, I think, one of the neater buildings on campus. It's got a great architecture, and it's really neat to see. De Jong is the same way. I think it's a neat building. Staff housing, we've got some area for staff housing. The fountain has special significance to folks who have worked here and been patients here. And then we talked about Adair and some of the other buildings. You'll see the old main memorial here, the bottom picture here in a little more detail after a while. We'll talk about that and how it fits into today. Go on to the renovations. So as I said, we've had to make significant renovations here on Adair side, on the Adair Hospital. Go ahead and go to the next slide. So the door handle seems simple. We see that door handle there. This is the old one. This is the new one. And again, if you're an employee here, you know the difference, but there are plenty of people who don't. The one on the left creates a ligature point because it will give a leverage point for people to wrap a piece of clothing or something on to hang themselves. The one on the right it's got a cone shape to it all the way from the base up to the handle itself, and it will give away if somebody tries to strap something over it, so that it prevents them from doing that. The door hinges is the next slide. The traditional hinge on the very far left picture is, again, that creates a leverage point where people could hang themselves. We had to put in, we didn't have to put in these specific hinges, but it was the best and the most efficient. That's a piano hinge is how they refer to that. It's monolithic, so there's no avenue for creating a ligature point. Door sensors on the top of the doors, so that if you trip the sensor there by hanging something on it, it'll trip an alarm and somebody will run right away. The first trip I took here, I had them set that off, and I think the nurse is still really mad at me because she came running as fast as she could, and we hadn't warned her that we were going to do that, but it's an effective method to address the ligature point. Ceilings, as I said, we had drop ceilings, and so they were low and they were drop, and you could get up there and hang a ligature point from the pipes or the drop ceiling frame itself. And we put in a monolithic ceiling, hard ceiling. You see the acoustical tiles that we had to put in after the fact, because if you've been on there, even though we made those renovations, it's not nearly as therapeutic as it could be and as it should be. It's very much a 1950s, 1960s dormitory style facility. And while we've made significant renovations at a very expensive cost, I think it's about $23,000 a bed. It's about $600,000, $700,000 per 30 beds. Even though we've made those renovations and improvements, it's still not very therapeutic, and we need to address that. Baseboards, we've had to put in new baseboards. The one on the left there is a wooden baseboard. It's an infection control issue. The one on the right and below, there's no ability to get a crack in that unless somebody would pick it off, and it's really hard to pick off. But to get to that, there's no avenue for infection concerns or tearing that off. They're very good. The chairs I talked about, the ones on the left are things that we were criticized for by CMS. They're lighter, can be used to pick up and throw, or they can be broken and pieces used as a weapon. The one on the right is the new chair we've purchased. It's plastic molded, and again, it's weighted about 70 pounds, so it's harder to pick up and use if in an altercation of some kind. Bathroom safety upgrades, the curtains themselves are breakaway, so you can't use those as a ligature point. Some of the things that we did in the bathroom were specially made for the facility itself. The electrical outlets we've had to cover, which all seems appropriate. The water fountains, I talked about those. You see the triangular sides to it, so it prevents a ligature point to be created. The closets, the old closets on the left, again, various ligature points there. The plastic molded cubby allows no ligature points there. The beds, we've already talked about that, and you've seen those. The phones, we've already talked about. The nurses station has been modified, and that leads us to a couple of issues that are really important today. So it's hard to see on this necessarily, but there are several buildings on this. One of the things the legislature required of KDADS this year, and I actually appreciate quite a bit, so thank them. Gene Vickery's here today and been very involved with us and concerned about the future of Osawatomie. But one of the things they did is they've required us to do a study of what it would take to get rid of some of the older buildings on campus. So the West Pavilion, Rush Building, West Cottage, Biddle Building, York School, and then pieces of Adair are included on the packet of information, but we're having an engineering study done to see what it would cost to demolish and remove those buildings, and we'll have that delivered to the legislature sometime this fall. I think we should be able to get that back by November 1, maybe December 1 at the latest. So the legislature has an idea of what it would cost to get rid of those buildings. Again, the next slide is a aerial photo of the hospital, and then we're going to kind of retread some ground here. The buildings that we have designated to be reviewed for destruction and demolition are the next parts of the slide. So it's West Pavilion, and again you'll see the dates on there. West Cottage, Rush, Dijon, York School, Biddle Building. And then if we're able to build something new, there may be parts of the Adair complex that we would also do that with. Any plan that we have, I would think that we would probably keep what we've remodeled at Adair, if nothing else. But we'll do a study. That doesn't mean that it's going to get done. The next pieces of the outline are the old main building. I told you we'd get back to that. The last recorded demolition at Osawatomie was done in 2002. It's the old main building. So what I've put in here is what it cost to do that for your information, so people have some perspective on what it takes. The bid on that was $65,000. The next document that's in here is the range of bids that we received for that demolition. So it was anything from $63,000. There was a change order of some kind to put it up to $65,000. But anything from $63,000 to $433,000. One of the things that we're going to be sure that we do is to do any architectural recovery that we want to do. So if there's woodwork or some other pieces of the facilities that have some value, whether intrinsic or sentimental, we'll do some sort of a review of that to make sure that that piece of it is addressed as well. I put that in here because I want to give you some perspective of what I see as Osawatomie going forward. So engineering study, we've begun, presented to KDADS, and then report due to the legislature January 8th, which is the day that they come back into session for 2018. So the next piece of it, of the PowerPoint, these are actually the responses we got from Correct Care when we put this out for bid last fall. We put this on a pretty fast track initially, and it's going, I'm sure, slower than what a lot of people want, but we're taking a very deliberate approach to the future of Osawatomie State Hospital because it's so important to the community and to the state where we land on Osawatomie State Hospital. So last year we put out for bid an RFP trying to get bids from several people to manage and build new or possibly remodel the existing buildings on Osawatomie State Hospital. But my vision is to have a new Osawatomie, completely new campus. I'm an advocate, and I know this may be controversial, but I'm an advocate of getting rid of some of those buildings. Maybe not all of those. There may be some sentimental or historical value to some of them, but we evaluate that over the next several months and decide which ones stay and which ones go. Often the first comment I get from somebody who's come on the campus the first time is about the Jejong building and how it looks in disrepair. I know we use it for some of the community, maybe the fire department and law enforcement, but the intrinsic value of having that removed and some of the other buildings removed, in my mind, when you compare that to what we can have new and at Osawatomie, is worth the value of considering making this a new facility of the 21st century and beyond, actually. So this is the actual response we got from Correct Care, and you have it in your packet. It's available. So the benefits and risks, I won't read those all to you. You all know how to read, but there are some advantages and disadvantages to the RFP response. To me, there's some efficiencies to be gained just from an energy standpoint. There's some efficiencies to be gained by the structure, the way it's built. If you followed the discussion about the situation at Lansing, you've heard Secretary Norwood talk about the efficiencies you can gain from reconfiguring the facilities we have over here. If you haven't been up here to see it, we have an architectural model of what a new Osawatomie State Hospital might look like. I'm not saying that this is what it's going to be exactly. This is built out to be a 210 bed facility. Again, we will probably keep Adair, the parts that we have remodeled at this point, but this is over here as an architectural model of what it could look like from the outside. We put up poster board that show you what it could look like internally, and I don't think you can make an argue that that's a much more therapeutic environment for our patients than going forward. Here's some other information about what some of the Correct Care models have been and how it could look for our patients. And really that's the bottom line, is what can we do to help our patients? So what can we do to make Osawatomie one of the premier psychiatric hospitals, mental health hospitals, really in the country, not just for Kansas, but in the country. And I think we can do that. We have the ear of the legislature. They're interested in this issue. They see it as the issue it is, and that's a good thing. That's a good thing for you as employees. That's a good thing for our patients for sure. And I think we can make this an outstanding place to work and to come as a patient when you need to come here as a patient. Some of the rest of this is up here, and you can look at it later, but it's all how their hospitals look now. One of the things that we did this spring when the legislature was on their break, their 3-week break, is my staff and I took a tour of, I think it was 5 of the facilities for Correct Care. They have facilities all over the country, really. They service, on any given day, they service about 275,000 patients nationwide. They have about 13,000 employees nationwide. They recently entered a contract with the state of Massachusetts to provide some services at one of their mental health hospitals. And I can tell you that when we visited their facilities, they were, I think, very well run. Staff was happy, patients seemed happy, the facilities were clean, everything seemed to be a very well run organization. One of the concerns that I know many of you have, if you are employed at Osawatomie, is, do I get to keep my job? And the short answer to that is yes. We have talked to not only Correct Care leadership about that. I met with probably 10 or so of the staff at one of the facilities who converted from state to private employment. And I'm not going to sit here and tell you that everything was perfect. They certainly had their concerns when it happened. But I can tell you that there were several people there who had been in state government and or with the hospital for up to 40 years. And while they expressed some difficulties initially and were nervous and there was some uncertainty, Correct Care worked with each person individually to work out their circumstances so that it worked for that individual person. They have promised me, and I think they will affirm that today, that if you can do 3 things, you will get to keep a job at Osawatomie State Hospital if we go forward with this. Again, this is a 210 bed facility. We'll keep Adair, so there's going to be plenty of work to be done by people that want to stay here. So if you can do 3 things, pass the background check, pass a drug test, and meet the minimum qualifications, which you already do, for your job, you'll get to keep your job. They've made that promise to me, and that's important to me that they follow through with that assurance. And again, so there may be people who are close to retiring from the state and concerned about that. They'll work with you individually for that. There may be other concerns you have about your health insurance. They'll meet with you and talk with you about that individually. And that's not just them saying that. I talked to several of their employees who converted from state employment to private employment. And again, not all of them were happy and singing Correct Care's praises at every turn, but they seemed very happy and they expressed happiness with their situation. And they had been at that facility since, I think, 1998. Was that right, Jeremy? Yeah. So 1998, so they'd been there for several years, and they all seemed and expressed that they were very happy with the position that they had there. So where we are with the RFP is it's been put out for bid. We had 2 proposals that were returned. One of them was late and probably wasn't sufficient, and so we were left with one RFP response, and it was Correct Care's response. And we've been working with them back and forth. They have had some more requests of information from us. We've had some more information we wanted from them. I wanted to visit their hospitals. I wanted to get to know their leadership a little bit better and understand the situation a little bit better and how things would proceed. And that leads us to today. As I said, I think we have an opportunity going forward to create a new Osawatomie State Hospital, and a great Osawatomie State Hospital. From the building to the staffing to really everything, we have the chance and the time and the moment to do that, and we need to take that opportunity. And so I don't have any numbers on their bid. We haven't gotten that far yet. I think it's premature. We're still waiting for some additional information from them, and they're waiting for more information from us before we would start bidding. One of the things that's important, and part of the reason that I'm glad to see some legislators here, is that the legislature has to approve this if we go forward with this effort. I think while I was frustrated with that when that first occurred, I think it's a sound policy on their part for them to have some buy-in to it and understanding about it and how that impacts you and how that impacts the region, the state, and certainly the county and city locally. I want this to be a great place. We worked really hard to try to get us in a position to make this a great place to have a great hospital. You all came from, I didn't have to suffer through the CMS surveys, but you all came through a very hard period at Osawatomie State Hospital, and I believe that you deserve the chance to be a part of a great Osawatomie State Hospital. I think this is a path to do that, and I think it'll be a good effort. The cost of this, the estimates are pretty broad, but I'm guessing anywhere from $100 to $170 million to put something like this together. Whether or not we do that through a lease purchase or an outright build will be something that the legislature and us will have to determine what makes the most sense to do that, whether it's a lease purchase or an outright build to the state. It's a rough estimate based on what I've seen from other hospitals that are being built locally and close by. Missouri's building a new state hospital in Fulton, and some of the information I've seen about what they're doing in Lansing. That's a rough estimate, and I think it's a fairly reasonable guess. I know it's a broad range, but $100 to $175 million is what I would guess it would take to build this out, and we'll work on the financing as we go forward. With that, I don't have any other presentation. I would be glad to take questions. I'd like to hear from community leaders first, and then I will take questions from staff as well. I don't think Correct Care had any specific presentation they wanted to give. They have some other PowerPoint slides that I'll ask Nikki to go ahead and put up so you can see what some of their other issues are. If you have specific questions for them, I'm sure they'll be glad to take those. But under the RFP, I don't feel comfortable having them get up and give a presentation to us today. I think that we need to keep it right where we are. So are there any community leaders, county legislative leaders that have any questions about the presentation today or concerns that you want to express?
Hi, Secretary. Leslie York with the Elizabeth Layton Center.
Yeah.
Just looking for clarification. The RFP that you're referring to is not just for facility improvement, but also for the service delivery?
Right.
For services
Yep.
in the hospital?
Yeah, so that's a great question, and it gives me a chance to answer that. That will be separate from the building itself. There will be a different rate that will be bid for or settled on for the service provision. And I can tell you what it costs at Osawatomie. It's about $616 a day to deliver that at Osawatomie, based on the numbers we put together with the RFP. I don't want to speak for them. I don't want to put them in a tough spot. I can tell you that they are providing those services at every hospital that I visited, because I asked that question, a substantial reduction in that amount and not providing less of a service to their patients. The configuration of the building helps a lot with staffing. They also have what I think is a really neat tool with an iPad. They have an iPad that they put, and I think they call it a PAM system. And so what it does, it's set for every 15 minutes for them to go find every patient and take a picture of that patient, and it records right to their medical record, the patient's medical record. So their 15-minute checks are forced to be done by the staff there, but it's very simple because they have, I don't know, 8 or 10 patients on each page of the iPad, and they just go around and find the patient, take a picture of them, and that records that they checked on that patient every 15 minutes or whatever the time frame is. It may not be 15 minutes, but whatever the time frame is appropriate for that patient. But the service delivery would be a separate part of the bid, and that's why I said it's not determined whether or not we'll do this through build a new building through the RFP or build it outright with the state. Yep. Go ahead.
George Brett, Miami County Commissioner. So when you present this to the legislature, apparently the legislature has the option to go private or keep it state employed, correct?
Yep.
So the RFP will state that the beds remain in Osawatomie,
The RFP currently says the beds will stay in Osawatomie State Hospital.
and there is an ability to peel any of those off and place somewhere else, even temporary or...
I'd have to look at it, Representative Vickery, and see what the RFP said specifically. I don't believe so, but that's not in the plans to do that
I guess
if we go with this effort.
Of course, we're having a lot of discussion about how our employees, the proposal would treat our employees, what that transition would be and how that would work.
Yeah, like I said, I can only tell you what I heard from current employees of Correct Care. And again, while they had some, not concerns, but they had some uncertainty with the transition from state employment to private employment. It was my understanding and my belief, after talking with those several employees, that they were able to work through most of those concerns.
And the construction, is that going to be by taxpayers, or will Correct Care, will they pay part of that?
It'll probably have to be a taxpayer initiative.
So we would own the deed to the property.
And again, whether or not we do that through a lease purchase or an outright purchase will be up to the legislature and what we end up doing on the building. We'll have to assess that as we go forward. But Correct Care won't own the building, if that's what you're asking. Did you have your hand up back there? Okay.
I was going to say, if we're going to do a tax increase to build the building anyways, then what's the benefit of privatizing?
Well, I don't think we're doing a tax increase to do this.
You just told him that it would be tax-funded building. You didn't pass that.
Yeah, but there wouldn't be any. There wouldn't be any.
The building in the first place. What would be the benefit of privatizing at that time?
I think there's a lot of benefits to privatizing. The main one is the resources that they're able to bring from throughout the nation. As I said, they have 275,000 patients, 13,000 employees nationwide. So I think they'll be able to bring in clinical staff and other staff to help staff the hospital with psychiatrists, doctors, those kind of things. They just have a bigger pool to draw from. That's kind of as we went around from facility to facility, that was one of the things that was pretty obvious, that they promoted from within, and they moved people who were doing well at one site to another. And you know that we've had staffing concerns here over the last several years. That's improved quite a bit. I think we're doing better on staffing, and you're shaking your head, Sue. I think you agree that staffing's better. But you know how hard that's been to get to that point as well. And they would have the resources to be able to help do that, especially at the higher clinical level. That's a big piece of it. I think we're doing okay with the number of doctors we have here, and we certainly have a high quality of doctor here. But it would be nice to be completely, fully staffed on that, and that'll be part of the RFP, is that they have to meet certification, get certification, and maintain certification throughout the contract. And I don't think that'll be a problem for them.
Will it address the issue that's why we lost the staffing in the first place?
I'm sorry?
Would it be just as beneficial to look at the documentation and see why our staffing was decreased in the first place?
Yeah, well, that's a bigger discussion we can certainly have, and we've had that over the last 18 months. What I'm happy about, though, is that we've addressed that. We seem to have really good staff not really good, excellent staff here, and we're much better staffing-wise than we were certainly even 6 months ago and 18 months ago. Yeah.
Contract terms on this, what's the stability in the provider? I mean, if they don't own the building and they're just providing the service, what's the long-term investment on the provider side, and how long would that be?
Well, right now the contract, and that's probably one of the things we have to revisit, is how long the contract will be. They've been around, and they can tell you they've been around a long time. So I think as far as their ability to be around, I feel pretty confident about that. But one of the things we'll have to look at is the RFP calls for a 5-year contract. We probably need to go out longer than that, certainly on the building piece, because it doesn't make much sense to build new if you're building for 5 years as opposed to 25 or 30 years. So we'll have to do that through the piece of the contract. Yeah.
What impact will privatization have on the mental health centers as far as us being the gatekeepers
Yeah.
for state hospital beds?
I'll tell you, that was one of the criticisms I heard from the CMHCs, that there wasn't, you didn't feel like it was sufficiently addressed. I think that Correct Care has been out to meet with the board. That's one of the things I've indicated to them, that they need to find a path to work with the CMHCs because they're so important to the mental health system. You are kind of the gatekeepers and everything else to the mental health system. So there'll have to be something worked into the contract and work with you folks to make sure that that happens, and you're not jumped over, you're not bypassed. You're too important to the system. Saw another hand go up. Yeah.
Mine wasn't up, but I did. What kind of treatment then will the patients get by getting all these changes in there with everything that's been changed? What's their day going to be like?
You know what? I'm not an expert on that. You have to ask them, the staff from Correct Care, and they can stand up and answer that question for you.
Okay.
Go ahead.
So we do a variety of evidence-based treatments. We have a treatment mall concept, so our goal is to get people off in their living area into a treatment space and make the most of a therapeutic environment for people who have more acute needs. Then we also provide treatment on their units, and it's a
Bless you.
mixture of skills building, psychoeducation, leisure, wellness, a full variety of different evidence-based treatments.
Music? Any music?
Yeah, music and art.
I have a question.
Yeah.
How many pharmacies do you have there?
How many
Is just one pharmacy, like a central pharmacy or something,
do you guys want to address
to
that?
provide the medications?
Correct, yes, typically each of our hospitals has a licensed pharmacy on site that's providing those to the hospital.
So it's going to be one pharmacy
Correct.
for 240 beds?
Correct.
Okay.
210 plus the Adair. Correct. But multiple pharmacists, so there's one licensed pharmacy which operates under a license and it's providing those medications.
I think that was her question, how many pharmacists there would be.
And again, I don't know that number off the top of my head. I'll have to pull out the Excel, but typically we have pharmacy during the daytime and on call, of course, as well, given the nature of especially in acute settings.
Okay, are you planning to open like more hours, or we work till 4:30 usually with the new facility, more patients? Are you planning to have like till 9 p.m. or have a second shift, or?
So again, based on this is part of the data exchange process, we'll be learning about that. What is the usage, when are the hours, and then obviously to make sure we have appropriate staffing during the entire time it was needed. Again, with the caveat that there's always going to be a need for on-call. And again, that's consistent with our other facilities.
Right. That's good.
Doctor?
With Correct Care, do they have any experience in the taking in voluntary patients that are court ordered and you cannot filter them, especially as per the Kansas state law pertinent to that?
Yeah, so the majority, the vast majority, and practically 100% of our patients are in our care because they've come in contact with a judicial process, either a civil court proceeding or a criminal court proceeding, depending on whether it's a civilly committed or a forensically committed. So out of the 2,700 patients we see in our hospital inpatient settings, I don't know that there's one that has not been in contact with a judge to in our entire care.
I'm going to go here because you've already asked a question. Go ahead.
Voluntary patient who's seeking assistance, are you accepting those patients?
Yeah, absolutely. So at South Florida State Hospital, again, it's just that generally they tend to be court-ordered. There are voluntary admissions, but not unlike the state of Kansas, the systemic pressures have been such that the safety net hospitals tend to receive almost exclusively court-ordered patients.
Yeah, go ahead.
Secretary, if you privatize and then subsequently build a new facility, whether it be through lease purchase or what have you, where do you envision the employment level being at in a new facility, and what would the census for the patients level be in comparison to where you're at today?
So as I said, this is this build out here is 210 beds. We would probably keep the 60 beds that we have on Adair that we remodeled recently. No reason to tear that down.
60?
Yeah, and that's where I think we would be. We're working on some other models to help build out some, not to take away from the hospital, but additional capacity to keep people closer to home. So we're working on what I call secure bed policy, so that people can stay closer to home if that's a better fit for them. Our agency motto is right care, right time, right place. And so we're trying to build out the system so that we can get people to stay home if they can. And then if they need to come to a hospital, I want them to come to a great hospital, a new hospital. Does that answer your question?
And then
and then the staffing.
What do you get from the staffing?
Yeah, so I've always said that we're going to need more people, not less. So I don't know what that number is, but we're going to need more employment, not less employment to do this. And certainly at the get-go, because we're going to build a $775 million facility, so there'll be some economic impact that way, of course, as well. So, yeah.
And so if you're going to be adding beds and capacity really in our portion of the state, for the basin, will Larned be maintaining their number, or will their number be changing? And where do you end up system-wide at capacity?
You know, I don't know for sure. We probably need to build into the system some more flexibility so that we can move maybe a little bit more of the criminal process to Osawatomie because of the staffing concerns we have at Larned as well. You're all aware that we have staffing concerns. Actually, our staffing concerns at Larned are much better, but they're still more acute than they are at Osawatomie as we sit here today. But
So theoretically, some of that capacity that you would be adding would be
right.
reducing by the shift.
Right. We're not going to take beds away from Larned, but we need some flexibility to be able to, on an occasional basis, to be able to bring more patients here for competency evaluations and other court evaluations. Yeah.
One of the barriers here is we don't have our SBU unit like Larned has. Would that be on Quick Care's plan to SBU? So like if someone's violent, we're not having to do a 3-hour ride, if we'll be able to
Yeah.
put them back on the unit?
Yeah, the short answer is yes. The short answer is yes. Their facilities, all the facilities of theirs that I visited, had capability to handle a broad range of acuity.
And Quick Care, what do you guys do with your traditional state hospital patient, the one that is acute throughout their whole life, that acute is their baseline? Insurance won't pay because how do you guys handle that to offset that cost?
Yeah. So again, we specialize in serving underserved populations in partnership with state agencies. And so the way that works is we enter into a contract relationship with the state agency, and then we don't have a refusal policy. So there's not any sort of picking and choosing for the private payers, this or that. They are the mechanism. Our goal is to function as an extension of the state. And so I think that answers the question in terms of that. But typically the patients that we care for are severely and persistently mentally ill. They typically have a long histories of mental illness. They've typically been in the system in one form or another at points of their career. They may have been involved in the justice system, and their time with the civil courts. And typically by the time they enter into our care, that is our patient. That is our specialty. And in terms of that, I mean, we've been providing these services for nearly 20 years on behalf of state agencies. So we're very familiar with that.
So like the criminal in the long term, or you guys are already aware that we don't get the reimbursement for
Yeah,
that, like Florida?
That's correct. We are 100% aware of that, and again, that is part of what we do.
Yeah, then I'll come over to you, I promise, okay? Go ahead.
Hi. So I'm just wondering,
Yeah, so and this kind of tags on to an earlier question about the SVU and that population. So typically what we do when we look at, we know that patient needs and demographics change over time. We know that at least in our facilities, and I think nationwide, there's been a trend where individuals tend to be sicker. We're seeing that more. And so what we do in each facility is there's this notion of kind of a modular design, where that any individual unit could be specialized for a certain needs, whether it's an acute or a subacute population. But we try to, on the front end, and again, encourage y'all to come and look, is to kind of think through some of those issues on the front end, so that if for the first 2 years a unit needs to be single occupancy rooms because there's a little higher acuity, but later there needs to be a vulnerable unit where it may be appropriate to have some double occupancy. We try to plan for that, and so that over time, operationally, it can shift. Likewise, we've seen, because we have no refusal policy, we've seen the proportions of civil beds and forensic step-down beds change, either go up or go down over time. To the extent we think through those things on the front end from the design component, we're able to address those as they emerge.
Yeah.
Might kind of piggyback a little bit on hers, but so with this, are we saying that the two separate hospitals will both be housed in this one, or will the two separate hospitals be one hospital?
It'll be one hospital.
Okay.
Yeah. Yes, sir.
Yeah, I'm speaking for those of us that have been with the state for a long time and aren't too far away from retirement. What is your timetable on this as far as when we might transition from being a state employee to a private sector employee? And what is Correct Care's plan to assisting those of us who, I've been with the state for 26 years, who have capers and deferred compensation plans and those kinds of things?
So the time frame I'm going to give you, it'll probably be a July 1st or January 1st, and probably either July of next year or more likely January of 2019. And the reason I say that is because we have to get legislative approval for this, and I don't want to move forward until we know that we're going to be able to get that legislative approval. And so I'll turn it over to Correct Care to talk about what their plan is.
Sure. We're only successful because of the people we have in our facilities around the country. So, and we understand the anxiety associated with your situation. As we go into this, and the Secretary said it, we want to try to hire, and we will hire everyone that meets those three criteria that we talked about earlier. No one goes backwards in pay. Benefits start on day one. The issue of retirement is one that we deal with once we don't have the data yet to show how many people are within 1 year, 2 years, 5 years. We analyze that and we try to come up with a program that makes sense for everybody involved. We don't want anyone that is operating in this facility to be hurt by this transition. That doesn't benefit us long term, definitely doesn't benefit you. So we want to do everything in our power to make that as seamless as possible and there not be any negatives associated with your compensation and your livelihood. Again, still have information going back and forth to know the specifics of what buckets everyone's in, but then we would come up with a plan, sit down with everybody individually, and talk through how that they're specifically impacted by any transition. Thank you.
Yeah.
So that transition then would occur prior to construction?
Probably so, yes.
So then what would be your time frame for construction if you receive legislative approval?
We would try to get that going as soon as possible. It'll depend on the financing piece of it, and I'll have to get back to you on that. But hopefully before I leave this job, which will probably be in early 2019, would be my hope that we can start on construction pretty quickly. This plan, as I understand it, puts the building just outside here, just outside basically where the parking lot is where the new building would go. And we'd work forward from there. So it'd be my hope to be a part of the groundbreaking on that, and it'll probably take 2.5 to 3 years to build out. Is that right? Did I get that right? 2 years? Okay, 2 years. You had a question?
What is the potential for the facility design and the services to also serve the child population should the need arise?
Well, most of that is done through the PRTF, so this would not include any children's services. This is an adult population that we'd be dealing with here. Some of we are working on some other efforts, and I can talk about that with you offline, but we're working on some of those issues with children. We've recently started a Children's Continuum of Care Committee in Topeka, and we've got a robust group going on addressing the children's needs in the state, from providing, again, a good continuum of care to children while they're in school, if they have to go to the PRTF and other places. I'm a fan of doing RSI-like model for crisis on a smaller scale for kids. So if kids are in crisis, we provide a place for them to go. I can go into detail on this some more, but we probably ought to do it offline. But this is an adult hospital. Okay, well,
One last.
sure.
You made a statement about we redid everything because of keeping the patients safe here, and redid everything. How many deaths have we had by hanging here through the years?
You know better than I do.
I know. That's why I'm asking the question.
What is the answer?
Well, the answer is probably 4 or 5.
And when was the last one that you remember?
I was here some years.
I know. When was the last one you remember?
Years,
15 years?
perhaps.
Okay. I don't know the answer to that question because it's been such a long time
Well,
ago.
Last 7 years.
What?
Me?
There's been one in the last 7 years.
Okay, 1 in the last 7. I've been gone 5. So we also had some issues with doing a lot of things with patients on the outside and things, and that's not allowed anymore. Is that correct?
I'm not sure what you're talking about.
We took them on trips. We took them out to activities away from here so they could see what the people were like away.
So I'm not sure that we're quite to the point that we can start taking people off campus, but we've done quite a bit, and other staff here can talk about that better than I can, trying to do it to pizza parties, correct care. When I visited with them, I think it might have been Good Friday, and they had a Good Friday celebration and outdoor engagement, and it seemed like that was a pretty consistent thing for them to do, to engage patients in a different way. So
Well,
that would be...
I know that was part of our things when our place looked really beautiful here and everything, but we took them many places, and they were long-term patients.
Yeah.
So.
Can we hear a little bit more about the no refusal policy from Correct Care?
Go ahead, Jeremy. Yeah.
Sure. I'm not sure, what's the additional clarification you're seeking?
When you say no referral or no refusal, I guess I'm wondering how true is that? Does it really mean? So prior to the moratorium, there was a system such that a qualified person from a mental health center would do an assessment. If that assessment determined hospitalization was needed, then there was no refusal. Regardless of payer source, regardless of voluntary and involuntary status, if that person needed to go, it was not able to be refused. Is that what you're meaning by
Correct. And so in the state of Florida, the facility that functions in a similar way to the way the CMHCs here do they're called receiving facilities, and they come through a receiving facility, and then if they are requiring a state hospital level of care, they're then transferred from the receiving facility to our care.
So they're triaged.
Yeah, that's
Pardon?
even if you don't have a bed.
And obviously, we don't operate over a licensed capacity. And again, I mean, one of the key components of this, we're recognizing that, you know, the hospital today is functioning at a percentage of what it once was. And to the extent that there is a bed available, that's made available, but we don't have the ability, if we receive that, if we have a bed, we provide it.
Any medical qualifications, if you have a patient with a medical issue?
We take everybody who we can. We do have an in-house physician, ARNPs, who do the medical clinic daily. We're on call. If somebody has cancer, we've had folks come in, we take them to and from their treatment. We've had hospice come in. If they're too medical that we don't feel is safe, then our medical director would talk to the medical director of the referring agency. It's all about the safety. If we can provide it in a safe setting, we will.
Yep.
So the receiving facility triages after the QIMP has said this person needs state hospitalization?
Say that again?
So the receiving facility triages, once the mental health center says this person needs to be here, the receiving facility then triages and decides if they go on to state hospital or go
We
where else.
receive the referral package from the triage group, and then we look to see what unit for us would be best suited for that individual, and then we set up the admission, correct?
But it's all for the hospital. They don't go to the receiving facility and then go back to the community.
The receiving facility for us, they would stay there for a little while if they believe they could get them stabilized quickly, then they won't come. If not, then they refer to us, we take them in. We work with what we have as a managing entity, which is kind of who you're going to work with the case managers in the community about aftercare. So we will work with the team who referred them, who manages them, about where to send them next to help them transition to the next level of care.
And how long can somebody stay in a receiving facility?
In the state of Florida, they can stay up to 6 months. Yeah, it's different per state. But typically, they'll be a referral and we bring them in within 2 to 3 weeks. That's our typical time frame.
Okay.
And that's longer than our current, because it usually at 63 hours is the current waiting list.
It's 48 hours is the average waiting list since the moratorium.
If I think the one thing, and so this is an important difference, so in each of our systems of care, we're working within the existing structures within the state. And so in Kansas, we recognize the way the behavioral health system is designed is different than Florida. It's different in Texas, where we operate 2 facilities as it is in Florida, 2 in South Carolina, 1 in Massachusetts, in Colorado, and Washington State. In each of these systems of care, there is just over time, there have been different models that have developed. So in Kansas, the model that we would adopt would be based on Kansas and working with community mental health centers. And so again, we're using the Florida because that's kind of the best example of the way the civil process works is a little bit different. And so the model of care was adapted to that. In Kansas, under our management, that the hospital would function and serve the same role that it does today.
They would have to follow Kansas law, of course, not Florida law. So, yeah.
I have a question for you guys. So you said that there's 3 simple steps to keep your job. You won't go backwards in pay. What about step increases? Because the state hasn't given raises up until this year for quite some time. How often do you guys do like employee incentives or whatever?
Annual performance reviews, and in the vast majority of our places, there's annual increases that are provided, COLA, CPI increases that we build in, to what we expect to do with our staff on an annual basis. So that's pretty commonplace, and we actually quite honestly need to do that to keep up with the competitive pressures as healthcare professionals continue to be more and more in demand.
Well, they used to do that here in Illinois. Just asking, I'm sure.
Somebody else had a question over here. Yes, ma'am.
What are your plans for the new building? What's going to happen with the fountain and the memorial garden that we have?
I don't know for sure. That's not part of the, if you listen to the whole presentation, or the legislature has directed us to find out what buildings might be a candidate for demolition. That's not part of the demolition process. It's my hope that we can do something with that. I think that can be a really neat space again. So I don't want to demolish it. Hopefully we can find a way to make that good again and use that fountain and that pool. I don't have any specific plans for that though. We got a lot of other work to do before we get to that point. Well, thank you all very much for the attention today and the questions. You guys have asked really good questions, and I really appreciate your engagement. I don't say this probably often enough. I try to say it every time I come here, but you guys have done a great job here at Osawatomie State Hospital and continue to do a great job. You interrupted my closing, man.
I'm sorry.
Go ahead.
I've been debating on whether to ask this or not. I'm a former security and a former fire safety up here. And if we go along with this new building, we have very old equipment here on grounds as far as to protect the buildings with the fire service that it needs. Would there be any room for upgrades to the trucks, the equipment that these guys use?
I'm a former firefighter outside of here, and I know that you need very up-to-date stuff in order to
Yeah.
provide the services for that.
I've not been asked that question, but I think it's a really good point, and we'll make sure that we get you involved in that discussion so that we can assess that going forward. So we'll make sure that we make that part of the discussion going forward. So we don't want to protect brand new building with 1930 equipment. I don't suspect it's that old, but it's
It may as well be.
yeah, I know. So that's a good point. So again, thank you all very much. I appreciate your attention to this today and involvement. Thank you.